Right, good afternoon, everyone. I'm Bridget Ryan. I'm an assistant professor in family medicine and epidemiology and biostatistics here at Western. And I want to welcome you to our third in a series of seminars between family medicine and public health. As many of you know, Dean Strong has indicated when he talks about our building being purpose-built, that one of those purposes was to foster research collaborations between family medicine and public health, and that's what we're interested in doing today, along with other colleagues from other departments on campus. So I first want to thank Dean Strong and Merritt Sorenstein and Emerdeep Finn for their leadership in this and all of our seminars, and I also want to particularly thank our event organizers, Kathy Thorpe, Diana Lee, Courtney Hammondies, and Maureen Kennedy for all of their technological help. And our purpose today, so the important part, our purpose today is the topic of the periodic health exam. We know this is of interest to both family medicine and public health, and we want to explore during our discussion time common interests that will generate research questions. So our goal today is to really be thinking about what our speakers are saying and have a really fulsome discussion that can move a research agenda forward. And if we're really lucky at the end of that discussion, maybe actually have a research question that people are excited about, or at least get ourselves part of the way there. So that's our purpose today. We have a little less than an hour because we were just waiting on some things. Each of our three speakers will have 10 minutes to discuss their topic from their particular vantage point. We're also going to have a short film about periodic health exams, very short. And hopefully after the presentation, we'll still be left with about 20 to 25 minutes for discussion. So I'm not going to introduce people in between, so I'd just like to introduce our panelists now. First up, we have Dr. Mark Schulich, who's an epidemiologist and a professor in our Department of Epidemiology and Biostatistics, and who is part of the Schulich interfaculty program in public health. We have Dr. Stephen Wetmore, who is a family physician and the chair of family medicine and chief of family medicine for London. And we have Dr. Ava Jean-Baptiste, who is a health economist and an assistant professor in anesthesia, epidemiology and biostatistics, as well as with the Schulich interfaculty program in public health. So I will turn it over to them.
Can you hear me? Hello, welcome, and thanks for inviting me. So I'd like to tell a story before I get to my slides. I'm not a physician, so I don't have patients, but I do have colleagues. And I was at Harvard 2 weeks ago with two of my colleagues here for a case teaching workshop. Walking back to the hotel, this guy who's in public health, but he has no health background, he's a business guy, started telling me about an annual medical that led to a high PSA result, which led to transrectal ultrasound suspicious finding, which led to color Doppler suspicious finding, which led to a biopsy, which led to blood in his urine and his semen, and a letter that said, "Congratulations, to the best of our knowledge, you don't have prostate cancer." And during this 6 months of hell, he had to, he and his wife were saying, "Can we tell our daughter that I have cancer?" and stuff like this. So this happened after I made these slides. So I thought I'd take this 60 seconds to tell that story, even if I'm running out of time as a result. So here's the history of the annual medical. It always seems like a good idea at the time. And the Metropolitan Insurance Company, post-World War II, said, how can it possibly be a bad thing to see your doctor every year? How could it possibly be bad? And that's when we were talking about having flying cars to get to work every morning. So this was the age of techno-rationalism, where technology is king, and the more testing, the healthier you'll be. And it was really that simple. The epidemiology was sound. This is part of secondary prevention. This is where you get your cancer screening, your prostate, and your breast, and your pap smear. And this is also where the doctor says, hey, you haven't had a tetanus booster for 10 years, it's time to update that. So now I've got the WebMD, which seems to be a well-accepted website by both physicians and patients, and I won't read the whole thing, but basically it helps people feel as healthy as they, reassuring that they're as healthy as they feel, detect things before they become serious. It's a cherished tradition, and I've underlined the word tradition. But there are no absolutes in the routine physical. So the words routine and absolute, you think would go together, but they don't. So there's no standard uniform definition. There's no place that I could find where it says this is what we do and in what order. There are variable frequencies, there are variable components running the whole spectrum of diagnostic maneuvers from various thumping and listening to invasive tests. They've been evaluated using RCTs, but there's inherently more variability in these evaluations than there is in a modern RCT. 10 milligrams of this pill, 10 milligrams of that pill. There's got to be more heterogeneity in both arms of every trial of this kind of thing. Well, this led to postmodern doubts, as most modern rock things have. And so the very first, this is one of the earliest applications of evidence-based medicine. And the first question was, well, how well does this thing work? And then when the first trials came out flat, the second question was, could it actually be useless? And then the more we looked at things, then the third question was, you mean it can actually do more harm than good? So what are some of the harms? Well, I talked about my colleague from Texas who ended up with blood in his semen and urine and a negative biopsy result. Possible harms are overdiagnosis, overtreatment, incidentalomas. The better our machines are at detecting little tiny aberrations of cells, the more likely we are to find these incidentalomas which have no pathological meaning. Distress due to false positives and evasive subsequent tests, labeling effects, insurance discrimination, and false reassurance from false negatives. So, usually the Canadians are 10 years behind the Americans, but here we were 10 years ahead of them because in 1979 we said there's no point in doing this. So now we have Cochrane. There's Archie Cochrane on the left. Who's that on the right? Sackett. The late, great David Sackett, who just died in May. So this has been looked at in RCTs. Their definition of what is a periodic appraisal. It's got to be looking for more than one risk factor in more than one organ system. So it's not just going in for just a plasma, it's more than that. Single or repeated, adults over 18, unselected, this is a key thing. These are people who are not sick. I mean, as far as we know, they have nothing at all. It could be done in the primary care community setting, but not a hospital clinic, and it could be any type of provider. Well, here are the three things, and you don't need to see it in great detail because here's the line of no effect, and there's cancer, and there's cardiovascular, and there's total mortality right up there, that thing. And so it's like, it's a flat pancake. You could not possibly find, I don't think, more negative findings than these. There were no beneficial effects of morbidity, hospitalization, disability, worry, additional physician visits, or absence from work. Not all trials looked at all these things. One trial found a 20% increase in the total number of new diagnoses per patient. One found increase in the number of self-reported chronic conditions. One found an increase in prevalence of hypertension and hypercholesterolemia. And 2 out of 4 trials found increased use of various drugs. But again, you'd have to ask, given the overall mortality results, why are we doing this? So the Cochrane conclusions are, there's just no point. It just does not do any good for morbidity or mortality. So as I prepared this talk, I was searching for a fair interpretation of the evidence, and I thought, well, first of all, we could be making a huge type 2 error. In other words, this thing does work, but we just missed the signal. So, the control patients in these trials, they had to receive something. There's no such thing as a completely inert placebo, because everyone has an opportunity to talk to a neighbor, a nurse, a doctor, whatever. So the control patients received something. Most trials are old, dating back to 1963, and we know the medical training has improved, and we know the technology has improved. So higher sensitivity and specificity plus better treatments improve outcomes if we started these trials today. I think that's a reasonable question. But the other interpretation is no, the correct conclusion was made. There's no good and possibly bad. If we increase the sensitivity of tests, we're just going to increase the incidentalomas. And without 100% specificity, we're always going to have some false positive findings, which can lead to overdiagnosis and overtreatment harms, which we have to do a better job, I think, of talking to patients about. Public policy and professional views are changing slowly. In my opinion, it's been completely discredited as a multiphasic thing where people with no symptoms or signs get a whole bunch of tests. I think that the evidence is pretty good that that does more harm than good. Things are changing though. Sackett has talked about ad hoc screening, so you go to the doctor with a sprained ankle and she checks for your blood pressure. We can also talk about maybe targeted screening, and there are several unanswered questions. Who should get it? What should they get? What are the appropriate compensation levels for this? Because the province is tinkering, as you know, with the compensation levels, sort of along this line. If you're a certain age range, the doc gets paid this much, but if you're another age range, the doc gets paid that much. And we also have to figure out the appropriate provider mix and follow-up. So back to WebMD, do you even need a physical exam? They're actually starting to talk about this stuff now. And they're saying, you know, it isn't very helpful. Well, I think that's kind of an understatement. Like, isn't very helpful means that it's somewhat helpful, but not very helpful. But I don't think the evidence supports that. Leading doctors and medical groups have called the annual physical not necessary in generally healthy people. So the future, last two slides. The first future is more research, high quality evidence by eligibility subgroups. We would incorporate health economics. My colleague will talk about that. We will contextualize benefit to harm ratios of different tests by formally incorporating patient preferences. We would talk to patients and say, what risk do you want to take of having blood in your urine and semen versus the possibility of a negative but not completely confirmatory biopsy result for prostate cancer. We would better understand patient preferences and how to discuss these things. And we would also consider the ethics of who raises this. And I think it is important whether the doc says it's time for your annual or whether the patient says, can I have an annual? Or, to be a little bit more cynical, the future is to move the goalposts. Maybe we're not talking about saving lives or reducing diseases. We're talking about building relationships with our providers. I think that's a good thing. Who can argue with keeping up a good relationship with your doctor? But is that a health outcome? Thank you very much.
Short video is next.
There was a time when an annual health exam was considered necessary and appropriate, no longer. We now do periodic health exams and investigations targeted to a patient's age and gender. The three key populations that we do periodic exams on are babies, teens, and the middle age. Babies get the most frequent periodic health exams. They are seen regularly from 1 week to 18 months, and after that yearly until age 5, to finish their primary vaccine series. The goal is to assess growth and development, administer vaccines, and address parental concerns. Teen girls appear for menstruation issues or the need for birth control. In teens, remember to check blood pressure and counsel about high-risk behaviors and drug and alcohol abuse. Pap smears are recommended starting at age 21 every 3 years until age 70 in the sexually active. If a problem arises, a woman may need more frequent pap smears. In some countries, pap smears don't start until age 30. In the 50s, we round up screening. For men and women, we start screening for blood pressure, cholesterol, diabetes, and colon cancer. At age 50, fecal occult blood testing is done every 2 years until age 75 if you have no family history of colon cancer. If you have a positive family history of colon cancer in first-degree relatives, colonoscopy is recommended 10 years earlier than the age your relative is diagnosed. In addition, women in this age group will also start getting mammograms for breast screening every 2 years from age 50 to age 75. There's considerable controversy when mammograms should start and just how effective they are. Also remember, at all periodic health visits, address risky behaviors, smoking, alcohol and drug abuse, diet, exercise, and immunization.
Well, thanks very much. I appreciate the chance to be part of this. I
going to start with a little story like Mark, although it doesn't end exactly like Mark's. Shortly after I started practice many years ago, I saw a 60-year-old woman came in for an annual checkup. I did a physical exam, which included a fundoscopy examination, a practice which I still follow. And I looked into her eye and I saw what I had seen in textbooks only, a swollen optic disc papilledema. She had absolutely no symptoms. Turns out she had a meningioma, a benign brain tumor, which would not have killed her, but would have caused symptoms as it slowly expanded over time. So I thought, this is what being a doctor is all about, right? Somebody comes into your office for a checkup, you find something which is a life-altering event, you save that person's life. I sent her to a neurosurgeon. Of course, they took out the meningioma. She was fine for many years, died in her 80s, and was my patient for all that time. So that's what many doctors, I think, hold in their heads and in their hearts as what constitutes being a doctor and doing annual health exams. But what are we talking about? These are the various different things that you will hear from patients, and you will understand that we're talking about here today. They're all equivalent. Annual physical exam, preventive health exam, periodic health exam, checkup, comprehensive physical exam, complete physical, general checkup. Just yesterday, I was working in the clinic at BFMC. I was going to see a patient on Team C, Stacy's team, and the nurse said to me, this next patient is here for this particular problem. You know, she hasn't had a checkup for a long time. Maybe you should suggest that she come in for a checkup. Which I did, and I'm not sure whether she made that appointment or not. The traditional components of an annual physical exam include a history, functional inquiry, where you review all of the systems, find out if they're having any symptoms in any of those systems, complete a head-to-toe physical examination, and then there's a comprehensive investigation and screening related to their age, sex, and so on. Mark has already outlined some of the history of the periodic health exam, so I won't go into that in detail. It did start from a need to have a general checkup for employment, for insurance, for various legal requirements. Doctors then adopted that as in the early days as a standard of practice. It was a good idea to get to know your patients, to have an opportunity to review their full health history and do a physical examination. In the 1980s and the 1990s, more and more evidence was coming out that a lot of the things that we engaged in as part of an annual physical exam were in fact not evidence-based. The evidence didn't support their use. We saw the rise of evidence-based medicine and articles, seminal articles and series of articles like the Rational Clinical Exam, which appeared in the Journal of the American Medical Association, talked about what the examination, all the different components of the examination, what was the evidence behind them, and none, as Mark has already indicated, none of those were very good. The Canadian Task Force and the Periodic Health Exam and the United States Preventive Task Force came out with recommendations that the annual health exam was not evidence-based. More recently, we've got things like Choose Wisely, the campaign that's organized through the Canadian Medical Association about being very rational about our test prescribing. And the Ontario College of Family Physicians has a program called Don't Just Do Something, Stand There. In other words, don't do something for the sake of just needing to do something. Consider what you're doing. This is what I've followed for all the different maneuvers I've followed for my head-to-toe physical examination on annual checkups that I've been doing for over 35 years of practice. I'm not going to go into all of those in detail, and these aren't all of them. I've got a couple of slides on this, but those are things that I normally routinely do. Only 2 of those are recommended by any sort of evidence that we have today. Blood pressure and pulse, checking the height and weight, both of those can be done by your office nurse or even a nurse practitioner. That's a little joke. The others are either not recommended because they're harmful or have insufficient evidence. There's no evidence to support it. These are some of the other things, including pap smears, pelvic examinations, breast exam, genital exam for males, digital rectal exam. When I was training, and many of the physicians in the room will have this experience as well, we were always taught that if you don't stick your finger in it, you'll put your foot in it. In other words, if you don't do a rectal exam, you're going to miss something and you're going to be in trouble. This is what's the recommended out of that crowd of physical exam findings. So the pap smear is the only one that has any sort of evidence-based recommendation in it. Pelvic exam for female, they actually recommend against doing that because it creates harm. Breast exam is either insufficient evidence or not recommended now, which created quite a stir with the issue of mammograms and breast examinations. Females were outraged, I think, to hear somebody say, well, breast exams are not recommended. There was a debate that appeared in the Canadian Family Physician in 2011. Michael Howard Tripp and a doctor called Ripolis, I believe was the other one, who was who argued pro-periodic health exam, while Howard Tripp argued against periodic health exam. And this reflects many of the arguments, which I think you've heard some of them from Mark's talk as well. So on the pro side, periodic health exam promotes the relationship between the physician and patient. You get to know your patient really well. Your patient experiences increased sense of trust because you're taking the time to review their health history, to do a full physical exam, to do appropriate tests. So that's a really strong promoter of the doctor-patient relationship, which we, of course, value very highly. It's an opportunity for you to focus on preventive measures. Many doctors find they don't have time in the course of acute care practice when people are coming in with various conditions, either chronic conditions or acute care conditions. You don't have time to go into some of the preventive health details that you would be expected to do if we didn't have the annual health exam. So many doctors reserve the annual health exam or checkup as a time to go into preventive health measures. It also is an opportunity for you to do a lifestyle psychosocial assessment. You may not have time at the other acute care visits to talk about what else is going on in their life. Understand the context of that patient. Patients expect a physical exam and welcome a physical exam. I really think patients like to be examined by their doctor. And so the idea of them coming in for a complete checkup really resonates with some patients. They may not understand the evidence behind it, but they think that the doctor talking to them about their symptoms and then doing a complete examination is a very satisfying thing for patients, especially if it's a negative examination. So it reduces patient anxiety, and there's little evidence of harm. This particular doctor argued that. Against the physical exam, there's no evidence of benefit. As we've seen, a lot of the physical exam findings and a lot of the tests that we order do not have any evidence for screening purposes. They may be harmful. They may identify things that would lead to investigations which aren't necessary, as Mark pointed out. Prevention should be part of every encounter. too time-consuming, too costly. Only in Canada. Other countries do not carry out annual physical exams or periodic health exams the way we do. And does not apply to all patients. Some people argue that the patients that come for their complete checkups and come repeatedly for annual physical exams are those patients that do not need to have annual physical exams. And we're missing out on the people, the homeless people, the people that are lower socioeconomic status, that have conditions which have chaotic lives. They don't come for physical exams. So this is my opinion, my last slide. I think we should continue the periodic health exam, but perhaps it doesn't need to be an annual exam. It could be done less frequently on people that are healthy. Well, the things that we do should be based on risk. They should be judicious. They should be evidence-based. And we do need more research into all of these different things so that we know what to order on the basis of the evidence. We should maximize the use of our EMR and other technologies. So we should have pop-ups within our electronic health records that identify this patient as a 60-year-old male, should have this, this, and this. That should come up right in front of the screen, and then we can address that at even acute care visits. So it doesn't have to be only at an annual health exam. I believe that the periodic health exam does enhance the doctor-patient relationship. I believe strongly in the doctor-patient relationship. I think it's important for family doctors to try and maintain this, and the periodic health exam is one technique to do that. And I don't believe it contributes to costs in a capitated system. Capitated system is where your roster of patients, you get paid a certain fee for that patient on the basis of their age and sex, and the routine visits for routine things do not generate extra cost for the doctor's visits at any rate. So I think a periodic health exam within that context should not contribute to extra costs. I really believe in physical examination. I think it's healthy for doctors to examine their patients. I think patients really expect and appreciate that, and it reduces their anxiety. It's a valuable source of information for doctors. I really remember things when I see them visually, or even when I feel things with my hands. And you remember significant physical findings on the patients. I bet all the doctors in the room can think of their patients and think, oh yeah, that patient has a carotid bruit on the right side. I listen to that every so often. You remember those things because you've conducted those, and you, as McWhinney says, you remember things about your patients over time. And physical findings are one of the things you remember. So I really value the physical exam, and I don't want to see that disappear. I think it does enhance the doctor-patient relationship, improves trust, and reduces anxiety. Thanks. Sorry I've gone over.
So I'm going to talk a bit more broadly about disinvestment, of which I believe the actions taken by the province in changing the fee schedule for periodic health exam and targeting with different age groups is an example of an attempt at disinvestment. Let me first put up a definition of disinvestment that came from a group in Australia, a working group meeting in Australia and New Zealand. The report, disinvestment relates to the process of withdrawing health resources, either partially or completely, from existing healthcare practices, including procedures, devices, diagnostics, programs, and pharmaceuticals that are deemed to deliver no or low health gain for their cost and are thus not efficient health resource allocations. So, a bit of background on my first exposure to this investment. This is a quote from a qualitative research study on hospital-based health technology assessment units. And I work in one that supports LHSC and St. Joseph's, the Medici unit. And in the hospital setting, technologies for which a request for evaluation is made are often already implemented in hospitals. So in this case, this investment decision support role, HTA units are often limited in their power to influence clinicians' behaviors that are already well entrenched. So that's kind of my first exposure, and we have specific examples of disinvestment health technology assessments that we've done. Here I'm just trying to sort of summarize the types of disinvestment opportunities that may be available within the healthcare system in general. And in generating this list, I've also, I think, touched on the fact that this general idea of disinvestment overlaps quite a lot with quality of care, improvement initiatives, implementation of best practices. And so we can think of the clearest and most obvious cases where we want to cease the use of something that's ineffective and harmful, and the use of technology there is very broad. It includes programs, not just drugs and devices. We want to discontinue use of malfunctioning medical devices, and that's in the hospital setting an important issue, maybe a very micro example of disinvestment, but certainly I think in that category. Decrease the frequency of routine care, and so the annual medical exam is a perfect example of that. Decreased frequency of screening, we've discussed, touched on the HPV and cervical cancer screening as an example, breast cancer screening where those types of opportunities exist, and of monitoring post-therapy. And then improving appropriateness, and so improving targeting of technologies and interventions to those most likely to benefit, decreasing the overuse or misuse of different technologies and health practices, decrease aggressive care at the end of life, or non-fatal conditions with minimal morbidity, like, for instance, ear infections. That's a common, ear infections in children, a common kind of disinvestment target. And then managing care with fewer resources. So I think Steve already mentioned that certain practices could be done, like by the nurse, that may have already been traditionally been carried out by a doctor. And so that can be perhaps a method of implementing disinvestment. So these are sort of opportunities that cross, I think, illustrate the general area of disinvestment research crosses a lot of domains. So what is the promise of disinvestment? I think releasing resources that can be reinvested in high-value technologies and increasing efficiencies. And I put a list here of disinvestment initiatives. I think at least one has already been touched on today. The National Institute for Health and Care Excellence in the UK, or NICE, has a do not do list. And this list has over 300 recommendations that have been generated from their health technology assessment process. And so when they perform a health technology assessment and find that a new possible technology isn't effective, then they put it on the do not do list. The Choosing Wisely from the ABIM Foundation in the United States has a website, one for patients and one for clinicians, and Steve touched on that. It's intended to inform the clinicians about things to think twice about, to choose wisely about, and perhaps not do. And also to inform patients, because often, as has already been touched on, patients are the requesters or the drivers of requests for this kind of care. Thinking Twice, Choosing Wisely, the Canadian version. And then the group in Australia has done a list of over 150 potentially low-value healthcare practices. So what are the challenges? The quote from Yoda, I think, is appropriate here. We don't like loss. And so I think that's probably one of the main challenges of this disinvestment in general, and then in particular disinvestment research. So as we lead into a discussion of research opportunities, well, the methods of conducting disinvestment research are underdeveloped. I think that it's challenging to identify opportunities for disinvestment and then appraise them. And I'll talk a bit about what has already been, what traditionally has been done for those resources to identify is mostly evidence synthesis. So we're not certain about what will be the impact of this investment, either in terms of patient outcomes and also in terms of costs and savings. And then there are interests of stakeholders, patients, clinicians, manufacturers, if we're talking about this investment in a drug or device. We have reluctance to change, vested interest, and then there are subgroups. And I think that's one of the biggest challenges with disinvestment. There may be a subgroup for which the particular technology and consideration is important. And we sort of touched on those patients that may not actually come frequently to the doctor. Maybe a subgroup that where a routine care approach actually would improve their health. And so there's always these considerations. So I was just going to think through sort of the challenges in terms of our PFOS framework, but in the interest of time, we'll just kind of move on to a bit of a discussion on what are the types of outcomes that are of interest. So ineffectiveness of a technology or equivalence, are we doing harm, or is it that we're not doing any better? Is that what are the outcomes that are of concern when we appraise disinvestment opportunities? Is it safety? Inefficiency is a very important driver. Cost, and as the health economist, I would suggest that it's not just the cost of care, but time and space, other opportunity costs. Is it feasibility and acceptability? Acceptability to the patients that of disinvestment, acceptability to the clinicians and other stakeholders, and is it appropriateness of disinvestment, appropriateness of care? So the current research methods that have been used mainly to identify disinvestment opportunities are really just evidence synthesis methods, looking at the literature on our efficacy, safety and effectiveness, clinical practice guidelines, practice variation. So one region may have higher use of a particular intervention than another region with no reason for that, or obvious reason for that variation. And then cost effectiveness. So something may be valuable but at too high a price. And then contextual information like experience and ethics and the issues with related to aggressive end-of-life care is a very good example of that. There have been a lot less experimental approaches to appraising disinvestment opportunities. Randomized controlled trials of disinvestment where perhaps units are in a hospital are allocated to disinvest in technology, pre-post interrupted time series. This has been very difficult to find. Observational studies, also difficult to find, particularly looking at disinvestment, maybe over time, looking at different hospitals, one that has, one that hasn't disinvested. Economic evaluation and decision analysis, there have also been a few studies specifically appraising disinvestment. They most often appraise investment, and it isn't necessarily clear that if something it looks bad in an investment HTA, doesn't mean that we should disinvest. So I thought I would just lead into the discussion about what are the research opportunities for disinvestment in the annual exam, other technologies, and identification and appraisal methods, which I think might be an area of research. So hopefully we can discuss that now. Thanks.
First of all, I want to thank our panelists for some great food for thought. And we have a short time for a discussion. I want people to feel that they can respond, but I would ask that when you're trying to respond, think of it in terms of going forward with research. You know, frame your ideas, your experiences through that lens if you can. You know, I just sort of throw out a couple of things. You know, we talked about, it seems to me we're talking about groups, and when we talk about family medicine and public health, we're often talking about patients and populations, and is that the same thing? And do we share the same values around that, depending on where we're coming from? And I think the way Ava kicked it off, you know, some of the outcomes that we're talking about in terms of disinvestment, are those all the outcomes that we need to be looking at? So I just throw those ideas out there, and I would ask everyone to raise their hand, and I'll just try to keep track, and ask the panelists to please feel free to jump in as well.
I just want to comment. I'm always intrigued when we talk about changing the annual health examination. We focus on outcomes for patients and the impacts on patients, whether things are valuable or not. We never talk about the value of the periodic health examination for the physician. And I think that Steve alluded to this in what he had to say, and I think that, you know, one of the reasons why I have more confidence and perhaps greater clinical excellence 25 years out into practice is not because of the abnormal stuff that I've seen, but because of the amount of normal that I've seen and felt. And I think that, you know, I have more confidence now when I do a rectal and feel a prostate nodule. Again, not because I felt that many nodules, but because of the hundreds and hundreds of normal prostate glands that I have felt. And I get very concerned when I think of the young physicians graduating now, you know, heading into potentially practicing where the expectations are that they very seldom look at normal. And I've even noticed, you know, again, I haven't researched it, but I've noticed even a subtle difference, I think, in the last couple of years since the pap smear testing has changed. You know, residents have cut the number of pap smears they do now by 2/3. One, essentially, used to do annual paps in my practice, we do one every 3 years now. And for male residents, it's probably even less than that because they're biased, I think, in the beginning against the opportunity to do paps. And I get a sense that there's more anxiety among residents around doing paps, about doing the pelvic examinations. And I don't know that anyone has ever measured this, but I think that there's a big impact here for the clinical acumen and excellence of physicians who are drawn away from kind of examination of normal moles, of normal cervix, of normal breast tissue. Just put it out there.
Okay, great. And I should have mentioned, Kathy, I know you won't be able to read it, but this allows us to capture and refer back just to some of these topics that come up that we can then share with everyone afterwards. And we will be following up with everybody after this event to see which people are interested in maybe pursuing something. Other comments? Just sorry. Hi.
This is just a comment which the experience which I had with one of the actually physicians. While I was doing my I was seeing my patient, and I actually counseled her regarding breast examination and breast examination during annual physical, that it is no more recommended and it doesn't add anything actually. So but when I talked to my staff, she said that, you know what, I will not say this to my patients because I recognize my own breast cancer because my self-examination during my physical. So I mean, it would be very hard, like you mentioned about the investment. So I don't know, it is also the patient's perspective, because at that point she wasn't talking about the patient, about the staff or doctor, right? She was talking from a patient's perspective. Right. So I'm not sure how easy it would be to take away all the things, or maybe rationalize certain things, or yeah. And again, if you don't see the normals, how would you appreciate the abnormal? I don't know how frequently are we doing physical exams in patients on routine visits.
Thank you. Good points. Amanda, you had a point, and then I am mindful we have some folks on OTN, so I should be careful.
Right. I just wanted to build on what Susan was saying here for a minute, because I'm thinking, you know, with the research hat on, and thinking, is that a question we can test, right? Like, what could we? I can't think of a whole research design at the moment. Sorry, but you know what I mean, right? That's something that you could think about. How could you test that question that's coming up? So it's from the training side of things,
Yeah.
not necessarily patient outcome, but it's an education training outcome.
Thank you. And I'm sorry, but how do I know if there's someone here looking to ask a question? I have no idea. Is anyone out there? Not here. Okay, here and then John.
Just to build on the point that Steve made, I think this idea of kind of prioritized populations who do require maybe a higher degree of support and intervention. How do we identify those individuals, and how do we kind of find the most appropriate people for the most appropriate care?
Yeah, you know, and you think of all the things going on about trying to use EMRs and or easily identifying subpopulations for sure. Yeah, and which again, as Amanda saying, that would be something that could be tested. No, sorry, John was next. I apologize.
Just a couple of quick points. I just think on what Sue said. Some things that we do, you do need to get some skill at to be able to do it well. And one of the slides showed things that there isn't evidence to do. Insufficient evidence doesn't mean we shouldn't do it. It means there's insufficient evidence. Rectal exam is a great example of that. And I fear as well, if people have not enough evidence, not going to do it. They lose the skill to ever be able to achieve that because it can have some doubt. It just isn't evidence. Things that we need to look on are where there's good evidence that it shouldn't be done. It shouldn't be done. Those are things we shouldn't feel badly about losing our skills in. The insufficient ones, we shouldn't let go too quickly. There's that practice element of it. That how much do you need to be confident in that part of it? Or Steve said, a bronchoscopy, is that something we need to have some confidence? You know, there's a number of different things there. The other point I was just going to pick up on that was alluded to in Ted's presentation, more so in Steve's, is that collective memory that patients have of seeing us, knowing what we do, but what we need as well. We remember things that we do, but that memory needs to get refreshed sometimes. And I think it really needs to be individualized how often that needs to get refreshed with different classes of people. As Ted nicely put forward, there's different folks, middle age, that a bunch of things go on happen. It's a good time to get a refresher, check in, tune in, do stuff. So the challenge with the periodic health exam is how to individualize that, not to get rid of them. But it should move away from annual, or as a run them through the car wash, everybody's the same approach, which I think we'd all agree should go and should never come back. Just put them through, don't think about it. This is where you catch up for the patient you got that done before. It needs to be individualized. It's important to tune in, remember, check on some things, see where we're at. Rather than leaving that to just happen automatically when people present on their own for a specific problem. Some people are more adept at others than stepping back after they address the problem and look at the bigger picture than others. But it does need some time wherever you decide to individualize and do that.
I think Merrick and Judy and Amanda, not missing anyone over here.
One thought occurs to me, which is that it sounds like there's actually quite a lot of variation in how different family physicians are using the periodic health exam right now. And I don't believe I've seen anything describing how it's being used right now, what people think they're using it for, and how many physicians are using, how many are examining how many of their patients and which subgroups of their patients. So I think there's a real gap in what we know about how it's being used now. And I think there would be some value in figuring out whether or not there's a consistent picture and what people would like to be using it for. I think that the comments we've just heard suggest that there might be a trend towards focusing it more effectively, but it would be useful to know what people think about that alternative way of thinking about the periodic health exam. And then the other question is, or the other issue that strikes me is that we talk about a particular activity as if it had value in and of itself. And we say, well, it doesn't do harm. It's not disrecommended, so let's do it. But that has an opportunity cost, and we often don't think about that. An opportunity cost is the thing that you don't do, that you might have done if you weren't doing this thing. And so when we say, well, it has value, what we really need to be figuring out is whether it has more value than the thing we might have used that time for. And disagreeing with my department head, probably not a good idea, but Steve, when you said there was no cost to the annual health exam under a capitated system, there's no financial direct cost, But of course, there's an opportunity cost. And so I think the other question that would be interesting to ask is, if we weren't doing periodic health exams on people whom we think we shouldn't do them on, what might we do with that time? Because the useful question is, which is better, to continue doing the periodic health exams where we don't think it's useful, versus doing whatever these other things are that we think might be more useful?
I just want to make a couple of points that to really reinforce some of the statements that were made by the panel. One is that Ted Osmond several years ago did a study looking at the importance of touch. And for me, touch is a vital part of the physical exam. And that patients wanted touch, and that touch was reassuring. Second study is a study by Tudor et al. Looking at family physicians' decision-making regarding screening when the screening guidelines are unclear or conflicting. So for example, classic one being for breast cancer screening. And again, what they found in their study, which was a multi-method study, mixed method study, was that one of the key issues was the patient-doctor relationship. And that is what informed their decision-making. It was influenced by patient factors as well as physician factors. Factors which everyone here has been discussing in terms of being patient-centered, patient anxiety, and on the physician side was sort of, clinical skills and peer pressure. And currently one of our master's students is actually doing a study looking at screening for lung cancer and whether or not it's appropriate. And again, a mixed method. So I mean, I think that there is research out there. I think that maybe it's somewhat scattered. It would be one of our first steps to really get a sense of what is out there and pull it in. And then I'm not suggesting it's a systematic review, but maybe that's the way that we need to go.
I'm very mindful of the time and that some people may have places they need to be. We could spend a few more minutes if people are able to stay, but if anyone has to go, I'd certainly respect that. We've already, I'm very pleased because we actually are generating things that sound like the beginnings of research questions. Talking about the education side of it, the skill side for the physician, what is the patient's perspective on all this, and how do we prioritize groups? If we all think that it's not everybody, then how does one choose what's appropriate? And then maybe just describing what's happening. Do we actually know what physicians are doing and can characterize that a little bit better? Opportunity costs, and then this whole idea of trying to pull all this literature together, that maybe there's things going on in different areas speaking to this, but this just hasn't been pulled together. So that's brilliant for the time we had. As I say, we will definitely be getting back in touch with the group that has RSVP. We have your emails, we know where to find you, and following up in terms of trying to bring together people that might be interested. We won't ask you to kind of declare that today, but if you are, then we'll be back in touch. So I'll conclude the formal part, but if people are able to stay and continue talking, that's fine. So I'll just conclude by again thanking our panelists for their time today.